Hi everyone, good morning. My name is Dr. Tochukwu Okwuosa. I'm a cardiologist at Rush University Medical Center, and I'm a professor of cardiology and the director of Cardio-Oncology at Rush.
Hi, and I'm Rohan Khera. I'm a cardiologist and data scientist at the Yale School of Medicine, where I lead the cardiovascular data science lab. And I'm very glad to be joining Tochi as the partner in artificial intelligence and precision medicine on our scientific statement.
First of all, I want to say thank you so much to the American Heart Association for commissioning this particular scientific statement, as important as it is, right? So I'm from the Cardio-Oncology part of the committees within the American Heart Association. Dr. Khera works with the Data Science Precision Medicine Committee, and we decided to come together to write the scientific statement along with a group of other authors from other institutions, particularly addressing the importance of artificial intelligence, precision medicine within the cardio-oncology. And why is it important? We know that heart disease and cancer are the #1 and #2 causes of death within the United States. Well, the thing is, as cancer patients live longer, because there's been a lot of advances that have been made with respect to cancer therapy, many of them are dying from heart disease. In fact, when patients have cancer and they get cancer treatment, cardiovascular disease is the main cause of morbidity and mortality amongst this population, excluding second malignancy or new malignancy. So it's really important to discuss what are the issues that lead to this particular cardiovascular disease within this population. And that usually is related to their treatment, whether we're talking about chemotherapy, targeted therapy, immunotherapy, radiation therapy, and all the newest stuff, stem cell transplant, CAR T cell therapy. All of these, each and every one of them, lead to different kinds of cardiovascular diseases, arrhythmias, really bad hypertension, heart failure, of course, is a common one that everybody knows and thinks about, ischemic heart disease, all sorts of things that can occur that can increase the risk, the morbidity, and increase risk of mortality in this population. So the ultimate question is, yes, we know these are issues that we see in this population, but how best do we manage them? How do we take care of these patients? First of all, how do we identify those that are at risk? Because we know it's not every single person that gets cancer treatment that's at risk. So how do we identify every single person that's at risk, and how do we then manage them? While taking into account the type of cancer they have, the stage of cancer they have, the treatments that they're receiving, the combinations of treatments that they're receiving, the cardiovascular risk factors that add to all of these. So there are many combinations and permutations of factors that go into making a decision on how best to identify these patients that are at risk and how best to manage them. So it's the complexities involved in this is the reason why we felt that it would be best to think about how artificial intelligence can play a role in identifying these patients and helping us further manage these patients. So I'm going to turn to my colleague, Dr. Khera. Dr. Khera, could you tell us a little bit more about what you think about artificial intelligence and how it plays a role in this sort of a setting?
No, I think Tochi summarized it perfectly for our listeners, that there is a big gap in how we care for these patients. We see a major clinical problem, and we see challenges in delivering them optimal care, ensuring that they have the best outcomes. The way, I'm a cardiologist myself, so I see many of these patients in my own practice, but I felt that there is a need to really better leverage the data that we have access to more effectively. And this doesn't really mean going and getting more, fancier testing and, more advanced technology, but using electrocardiograms or imaging databases more effectively in identifying people who are at high risk for adverse cardiovascular outcomes, especially in the cardio-oncology setting. To highlight the fact, our statement brought together so many experts from across there were so many engaging conversations about this. Right. We had card-carrying cardio-oncologists in the room, general cardiologists like me, folks who are pure informatics experts, oncologists, and then folks who are are more on the biological discovery spectrum, thinking about how biology plays a role and what new biomarkers come from the biological spectrum. And then to kind of synthesize all of that in the context of AI and precision medicine, cardio-oncology, it was a fascinating conversation discussion.
Absolutely. We learned a lot in the process. And some of the things that we want to point out about the statement are like the initial part of it, we particularly focused on risk assessment, right? So we think about the cardiovascular risk markers that we can use in identifying patients at risk, and how we can tailor those leveraging artificial intelligence in helping us assess those risks in future. So we talked about imaging biomarkers, whether we're talking about echo, of course, is a pretty common one, with strain echo playing a role to a certain extent, cardiac MRI, cardiac CT scans, EKGs even, nuclear imaging of some sort, like PET imaging and so on, how these imaging biomarkers could play a role. And then we also have a different section that focuses on the typical lab data, lab biomarkers, right? So we think about troponins, BNPs, and other biomarkers that people have been kind of assessing in the cardio-oncology population that may play a role in future, present or in future. And I want to, in our scientific statement, tables 1 and table 2 particularly focus on these biomarkers, thinking about how we're using them now and how we can possibly leverage them in future for using artificial intelligence for better precision medicine in managing this patient population. And then Dr. Khera, table 3 particularly focuses on the glossary of terms and the sort of,
I think the
to help people understand better.
I think the idea is like, many people who will read these statements will be coming at these domains for the first time, engaging them because there'll be clinicians who have not encountered them as effectively. So table 3 focuses on that and actually cross-references many of the themes that are present throughout the statement, as well as through tables 1 and 2. And I think that, as you said, tables 1 and 2 have is the meat of the article, because
Absolutely.
it really focuses on the idea that they have they have existing biomarkers and how we use them, whether they can be enhanced with artificial intelligence further,
Right.
and are there newer data streams that we always like electrocardiograms, we could view them, we could interpret clinical abnormalities, but now there are emerging AI applications that identify who would have cardiotoxic effects from any of the cardiotoxic chemotherapy agents. So I think there is so many discussion points there that are highlighted in those tables.
Right. And could you also comment on the biologics and the thoughts about the biologics and how these would play a role?
Yeah.
Right now, I think a lot of them are still in the research phase for the future.
I think from a purely, as you said, even treatments are evolving with immunotherapies and targeted therapies. We're seeing so many new toxicities, and to define a precision signature of who should have be on therapy and what should we monitor them with is certainly one we will go after. And then I think we're seeing so much on the measurement side too, with all the omics applications, with genomics, proteomics, metabolomics, where we're seeing newer markers emerge in the bloodstream. But we also, I want to highlight one aspect. We were very cautious in not making broad proclamations about value propositions of individual modalities, because it's not always possible to say that, oh, we will be doing metabolomics at scale.
Right.
Because we have to care about, every health system, every population, every patient who gets these care, can they get the test of choice? So we actually have this great figure 2 in our study, which highlights how often is data stream already available in our health system. What kind of information can we leverage from these data streams? And finally, what might be their time horizon for their application, and how many patients may be impacted by that. And I certainly would say the readers should definitely view that. It's a schematic of sorts, but it really highlights the fact that some data are so prominent that any application would actually have a much larger impact than some data streams that are less prominent, even if they're richer.
Right.
They would not have the same impact.
Right, absolutely. And other figure that we have there, figure 1, talking about the application of some of the markers that we have and how we can use them in cardio-oncology and leveraging artificial intelligence. Some of the ways that we thought about that these could be used is, for example, the typical electronic health record, which is the bane of our existence in medicine overall, is being able to leverage information that we have within the electronic health records, harvesting data from the electronic health records, and using machine learning methods to learn how these data have been applied and what they could potentially be applied to in future using, again, artificial intelligence. Again, like I said, when we were writing this paper, we learned so much from it. And then the paper basically concludes by assessing the limitations of artificial intelligence. Whether we're talking about the introduction of bias, whether we're talking about possible errors in harvesting data that's already there, and other sorts of issues that data privacy. There's so much other issues that we have to think about, and we didn't want to create a statement where it's like, oh, this is all very good and everything is all well, but just generally thinking through it in a very thoughtful manner to say, here are the problems that we may have in future while we're using this, but then we also know the benefits, and so we have to find a way to play a balance to ensure that we have the best outcome for data harvesting and for our patients.
Yeah, and I think, to our point, we had this real call out at the end of this. We really didn't, we wanted to say that if you're going to use existing data in patients who seek care in advanced health settings, then their data have this confounding effect of the fact that they sought the best care, they had the best outcomes, and you're going to deploy the tools you develop in all settings where the care quality might be different or the available resources might be different. So there is a different call out. And that we really, you know, and Tochi mentioned this specifically in our conversations, there's a need to build a much more diverse registry of sorts explicitly for cardio-oncology that has these elements in that. Don't you want to talk about that a little more?
Yeah, no, I think that's important, creating that diversity, right? So we have a diverse patient population, and I've already mentioned the different ways that each cardio-oncology patient is diverse. Separate from the regular cardiology patient, right, where you're basically focused on just the cardiovascular risk factors. In the oncology patient, you're focused on a whole lot more. Their cancer treatment, their stage, their type of cancer, and so on and so forth. So that diversity is already created there. And then we also have to think about diversity of the population, whether we're thinking about diversity by sex or gender, by race, and so on and so forth. And this conglomerate, we have to figure out a way to harvest all of them. One of the things that we pointed out in the paper is making the possible use of EKG, right? Practically every cardiology patient out there gets an EKG for one reason or the other. And there's so much data stored within each single EKG. And how can we leverage the information from there to apply it, to use it in, for leveraging machine learning methods to then be able to create that artificial intelligence in order to better manage these patients using precision medicine. So again, EKG is one thing. There's so much else that we discussed in this paper, and it really is a very rich paper. When we got the reviews back for the paper, we had 6 reviewers, right? Every single reviewer had great things to say about the paper. I mean, of course, they pointed out ways that we could improve the paper, which we have done, but there's so much contained in it, and we cannot overemphasize how it can be used to start the initial conversation and think about the initial steps moving forward to manage these patients.
And even the EKG study that you mentioned, we have a reference out there that actually references one of the AHA Family Journal articles on circulation, cardiovascular quality, and outcomes that highlights this paradigm where ECG photos can be used to identify those who might have anthracycline or trastuzumab-related cardiotoxic effects. So there are many links to our family of journals and published articles in those domains that that readers can then link out to and read more about. And I think, one thing is we summarized, but we also created this really rich glossary of references from across the field that actually other people can go read and learn more about this. And I think that's really very useful for the reader.
We want to end by saying thank you to each and every one of our writing committee. I think there were 10 of us all together, right? Thank you to each and every one of them.
And we hope to bring back a future version of the scientific statement with the advances this field is
definitely
definitely
that would be
have.
Great. Exactly. Those advances
perfect.
would be wonderful
so
that we can kind of continue to move the field forward.
Absolutely. Thanks so much.
Thank you.